All right, this is going to just be a short voiceover regarding the content we didn't get to in Thursday's class. I think we might have already covered this, but it's not going to hurt to review. So hemodialysis. So very similar to peritoneal, except these patients are going to have an artificial kidney to filter their blood through an extracorporeal machine. They're not going to be using their peritoneal cavity. But the process of solute and solution movements are going to be very similar. So we're going to be using diffusion, osmosis, and ultrafiltration. So very similar to peritoneal, diffusion, we're going to move solutes from an area of higher concentration to lower. So when the dialysate solution moves through the filter, it never mixes with the patient's blood, but it will usually run right next to it. So the patient's blood, obviously, if it hasn't been clean or dialysized yet, it's going to have higher concentrations of solutes to the dialysate solution. And so that's easy to understand, is then the solutes from the patient's blood are going to kind of move over into the dialysate solution. And then they're going to be returned on the other side of the circuit as waste or effluent. Okay? So that's kind of the main purpose of dialysis. So solution removal, right? These patients, if they do urinate, it might not be enough to compensate for what they've drank. So by the process of osmosis, we're going to move fluid to an area of higher concentration. So the dialysate solutions might have a higher osmotic concentration, maybe determined by a dextrose. And so the fluid in the patient's blood is going to move to that area of higher concentration in the dialysis, that high dextrose content. And then that excess fluid is going to be pulled off as waste or effluent on the other side of the dialysis machine. And then ultrafiltration is just another method to remove the excess fluid the patient is unable to excrete. We talked about access sites and that we need large surface areas for the massive amounts of blood we're going to exchange. And it's also for high pressure as well. So we're going to use an AV fistula, an AV graft, or we could use something that's very similar to a venous access device or like a triple lumen. And those are going to be VASCATs, permacaths. Both of those are more temporary venous access devices until we can get something more established like an AV fistula. So if we happen to see a patient who does have a VASCAT or a permacath, we know that this line is to be used only for dialysis. So it's considered a dedicated line only for dialysis. But because it does look like a triple lumen and it does sit in a vein, a larger vein, we can at times in emergency situations use it for IV fluids, antibiotics, blood, but we do need a physician's order before we use it. And because there's usually a 2 lumen, sometimes there might be 3, and it's a very large diameter, and we need to make sure it's patent, we're going to use a heparinized solution to actually sit or dwell within those lumens. Okay? So it's always important to make sure that before you access or use that line, that you pull the heparin out. If not, you're going to be injecting a heparinized solution into a patient that's probably sick if they're in the ICU. That's just another picture of the VASCAT, and you can actually see the 2 lumens, and you can see the CC markings at the end with the clamps that show how much heparinized solution needs to be dwelled. All right, so let's talk about AV fistula, and I think we did talk about this in class, but again, won't hurt. We know that this is the most common type of long-term dialysis access. Okay, it's usually going to be seen in a forearm, but it sometimes can be seen in the upper arm or maybe in the leg. But it's going to be created by connecting or anastomosing an artery and a vein together. And then over time, when this fistula matures or when it's ready to use, that vein that has been connected with the artery is actually going to be more arterialized. So it's still going to be a vein, but we're going to be able to use it as a higher pressure. So when the fistula is actually accessed for dialysis, when they put needles in, and we'll talk about that process a couple slides later, it's actually inserted into this arterialized vein. It's never put into the artery because that's there's a lot of risks with that. And the hand is still going to need that artery to perfuse. So we're going to use the arterialized vein, the vein that now has high pressure, to move our blood volume over a 3 to 4 hour period. AV fistulas are better to use over grafts because it's more natural. We're actually using the supplies of our body that we already have. It's more natural, it's more intrinsic, so you're going to have better patency. So it's going to work more in line with your patient's body. So you're going to have lower rate of complications, less likely to clot as compared to a graft. I mean, there are still a lot of complications and adverse outcomes with fistulas, but not as compared to grafts. So you're going to see a lot more fistulas. Like we said, common in the forearm. And so some big important nursing considerations is because now you've got this connected vein and artery, and so now you've got a high kind of pressure within this arterialized vein. There's a lot more blood flow through that area, higher pressure. So you're going to have a bruit if you put your stethoscope to it. And you're going to hear a lot of turbulent movement. And if you put your fingers on it, you're going to feel that thrill or that pulsation of the blood continuously moving through. For somebody with a fistula, there's a couple things, making sure that affected arm, we're not doing blood pressures, IV sticks, blood draws. Avoid lifting or carrying any heavy objects with that affected arm. Avoid sleeping on that arm. All right, so let's talk about an AV graft. It's going to be made of synthetic material or Gore-Tex, and it's actually going to make a loop to connect a vein and an artery together. So instead of anastomosing the vein and artery directly together, we're actually going to take a synthetic material and attach a vein and an artery in the forearm or wherever we choose to do it. So you've actually got like a synthetic device that's actually inserted in your body. So it makes sense why it doesn't work as well as a fistula. It might be because the patient doesn't have adequate circulation as is to make the anastomosis naturally between the vein and the artery. So we might have to go to a graft. There's more higher infection rate, which makes sense. We've got a synthetic device in the patient's body. So just like a fistula, we need to wait for it to mature, for the attachments to settle, to stabilize, to become a little stronger. So usually we'll stay somewhere between 2 to 3 weeks once they're mature and they're ready to use. So nursing considerations, similar to what we talked about with fistulas, no blood pressures, IVs, or venipunctures in the affected site. I would minimize sleeping on that side, carrying things. Aneurysms can develop and rupture in the affected area, especially if that graft is not seated well into the vein or the artery on either side. It could pull away. And then two, because we actually are, in some respects, stealing a little bit of blood flow from the artery, we can actually see decreased perfusion to the affected hand, like below the level of insertion. So we would probably need to report any kind of pain or coldness of the extremity, to the nephrologist or to the surgeon who has done the synthetic graft. So VAS casts, we're going to talk about this just a little bit more. VAS casts they're considered venous access devices, but they're bigger than a triple lumen catheter, bigger than a PICC line. They can be placed at the bedside. They're not a tunnel cath, so they are placed directly into the internal jugular or into the subclavian, very much like a normal central line. They terminate the exact same place that like a central line and a PICC line does. And then some of our other tunneled catheters, like a permacath, you might see those for up to about a year, but most of the time they're not used long term. And then in some circumstances, when patients are not able to get fistulas or grafts, they may have long-term tunneled catheters. So as long as they survive and as long as they need dialysis, that they'll use a tunneled catheter. It's not optimal, but sometimes it's the only thing that they've got. Like we said, we can place a venous access device into the internal jugular, the subclavian, or the femoral vein. We don't like to use the femoral vein a lot because it limits the patient's movement, right? And it's going to put them more at risk for DVTs with subsequent PE. And a patient who's on dialysis doesn't need any more setbacks, right? So like we said, short-term access more commonly. So obviously we said femoral, we don't like to use that, so those patients would be on bed rest. Again, if for some reason internal jugular subclavian is not an option and we need access quickly, we might have to use the femoral approach. High rates of infection, dislodgement, and thrombosis, which all make sense because those are our biggest complications with other venous access devices like PICC lines, central lines. The hemodialysis procedure runs typically over 3 to 4 hours. We says it's 3 days a week, usually Monday, Wednesdays, and Fridays, Tuesdays, Thursdays, and Saturdays. Sometimes in emergency situations, they might have to do an extra treatment, especially if another one has been stopped early for some reason or the other, or maybe they're in the hospital and this is a new patient needing dialysis. They might have to do 4 treatments per week versus 3. But more commonly, we're going to see 3 to 4 hours a week. So if this is a fistula or graft, going to be accessed in a little bit of the same technique. They're going to be large gauge needles, 14 to 16. There's going to be 2. If it's a fistula, they're both going to be kind of put onto the venous side. One's going to be pulling the blood to the dialysis machine. The other one's going to be reinfusing the cleaned blood back to the patient. If it's a graft, we're actually going to be accessing the graft directly. So if I can go back to these pictures where you can see, so this is the graft. So if you've got a 14 or 16 gauge needle on one side and then a 14 to 16 gauge needle on the other side. And then here, if you can kind of see the fistula, in the vein, you're going to actually have 2 needles, one down here and maybe one up here. Like we said, it's pretty dangerous. We don't want to continuously have to be catheterizing the artery. And then over here, we've already got this surgically attached, so it's not like we're continuously directly inserting into the artery. All right, so we talked about the needles. Like we said, one's going to pull the toxic or the dirty blood from the patient, and then the other, after it has been run through the dialysis machine, we've pulled the solutes that we need to, pulled their BUN and creatinine down, pulled the excess fluid off, tried to balance their electrolytes. That clean blood that's as close to the blood components that we want in the patient's body, we're going to send it back. The procedure itself, it's a very long tubing circuit. It needs to be primed with saline prior to starting the pool, because if not, we will actually return blood or return air to the patient. So it's very similar to priming like an IV prime or an IV piggyback. So even though we start pulling blood from the patient, there's always a lot more air in the circuit to start with. So we always need to make sure that the circuit is flushed with saline to make sure there's no air in it. Because this is definitely the time where we'd be considered about an air embolus. So when the procedure is over, when the 3 to 4 hour run has occurred, we're going to make sure that we return all of the blood that's actually in the circuit back to the patient. Because sometimes the circuit and the dialysis filter can hold up to almost a whole bag of blood, equivalent to what we would get, like 300 mLs of fluid, which almost is equivalent to a packed red cell that we would transfuse a patient. And so that's pretty significant. So if we didn't give what was left over in the dialysis circuit back to the patient, we'd actually be dropping their blood count, which is not something that they need, right? These patients are at risk for anemias, coagulopathies anyhow. So we want to make sure that we give them all their blood back. We want to make sure that before we start the procedure, the dialysis tubing is primed adequately with saline to eliminate any air. After the needles are removed, whether it's a fistula or a graft, firm pressure needs to be applied for a while, right? We said even though in some cases we're not directly inserting this into an artery, they're still very big lumens. There's a lot of high pressure. So firm pressure needs to be applied. We worry about bleeding. So obviously, definitely an important slide. What are the complications of dialysis? Blood loss. So blood loss if there's some bleeding at the fistula or the graft sites. Bleeding if we don't give back the blood that was left over in the dialysis system. Hypotension, this is definitely a big complication, right? We're pooling so much blood in a 3 to 4 hour window. And some of these patients aren't rock solid stable anyhow, so hypotension. So what we can do for these patients is we can slow down the dialysis, how fast we're doing it, okay? The patient might not like to be there in the center that a lot longer, but it's better for them, okay? Because, we just don't want to drop their pressure. They feel bad, right? Altered mental status, it affects the perfusion to the other organs, complicates the process. We may not be able to take as much fluid off from the patient. So slow the infusion. In some cases, which seems contraindicated, we might actually give them saline back. We might give them a bolus of saline or albumin. So definitely seems not correct when we're trying to take fluid off, but we want to make sure their pressure's up. And we might put them in the Trendelenburg position, so put their bed flat for a little bit, put their legs up. Muscle cramps, definitely could be related to the hypotension. Pooling, the disequilibrium, we're exchanging electrolytes. We are replacing their electrolytes so quickly, pooling BUN creatinine. So even though it's the outcome that we want at the end, sometimes there's this disequilibrium, as the process is occurring. And so the patient may temporarily have some muscle cramps. So again, slow the infusion, slow the process, give them some time to adjust, adapt, and then give them a little bit of normal saline. And then we said blood loss. These patients are at risk for folic acid deficiencies, anemias, because we actually can lose a significant amount of folic acid in the blood circuit, the dialysis circuit, that can't be given back to the patient. And hepatitis, hepatitis C, hepatitis B, patients are at risk. I think those risks have decreased significantly over the years. It's still important to kind of put out there. Nursing interventions, like we said, assessment is the key. We talked about before the process, making sure there's like Brewy and Thrill. Okay, do we have a good access site? Is there adequate patency? Yep, remembering no BPs in the affected arm, whether it's a fistula or a graft. When patients are getting dialysis, they're going to be getting their vital signs checked frequently. And then, of course, we've got autonomy. So if we feel like the patient needs to be checked more frequently, depending on how they had responded initially, we can do that. Temperature is an okay thought, but I think the blood pressure is a higher component. Weight. So we're always going to make sure that we know what the weight is before and after. Patients who are on dialysis, whether it's an acute kidney injury or chronic, they always know what their dry weight is. It's just like what their baseline weight is, what we want their weight to be. Okay? So we'll talk a lot about dry weight, and that's our target when we're taking fluid off with dialysis, getting them to their dry weight. What are their electrolytes before and after? So some of the key electrolytes that we obviously will watch: potassium, magnesium, phos, maybe a little bit of sodium. All right, so CRRT. So similar to hemodialysis, the thought process behind solute solution removal is similar, but we're going to do it slower and more continuous. It's going to be done over a 24-hour period. So we said with CRRT, these patients are sick. They're hemodynamically unstable. So we can't abruptly pool fluids alter their electrolytes that quickly. Okay. But some of the things that we can do in addition to pulling solutes, right, cleaning their blood, making sure we pull off the toxins, pulling off a little bit of excess fluid, not only by osmosis, by ultrafiltration, we can also clear, in this type of dialysis filter, we can actually pull off cytokines, chemical mediators that are responsible for the inflammatory process in patients who have septic shock or an inflammatory response syndrome. So it's really ideal for patients in the ICU who, if we can get to it and use it quickly, they have better outcomes. So yes, dialysis, fluid removal, but we also use it as a opportunity to help patients who are in a SIRS response or septic. The filter itself actually kind of collects those cytokines and those chemical mediators. It's very cool. So like we said, it is more optimal sometimes than hemo because we're doing it so much slower, and the way that it works is much more in line and comparable to the normal kidney. So obviously patients are going to tolerate that better, right? But we can only use it short term, right? 30 to 40 days. And that's because the patient can't get up and walk, right? They'll have to more or less be stationary because the machine is very dependent to movement, coughing, transfers. There are different modes within the CRRT depending on what you want to use it for. So, for example, scuff, that's more just slow, continuous ultrafiltration. The term ultrafiltration is just to remove fluid. So sometimes patients who come in with decompensated heart failure and they are unresponsive or unable to be diuresed through Lasix, Bumex, Demodex, we will actually hook these patients up to a CRRT machine. We don't necessarily need to do dialysis where we remove their solutes, but we can actually just remove fluid slower, and then they actually do better. And then the more different modes, the higher you go, the more, I guess, intrinsic anemones of the CRRT that you add to it that you can do, as far as replacing electrolytes, doing dialysis, right? Removing fluid too. So the different modes just depend on what you want to use it for. So we talked about the benefits, right? Fluids, toxins, electrolytes, and acid-base balance. So the disadvantage, right? It's expensive. Most often patients or nurses who are taking care of CRRT, it's a 1-to-1. Sometimes if it's a well-maintained machine, the patients aren't that sick, they don't have a lot of needs, the nurse might be able to have another patient. But most often it's a 1-to-1. So expensive, right? We need more nursing staff when nurses have 1-to-1s. Prolonged stay in the ICU, yes. It is harder to wean from the ventilator with a lot of alarm fatigue because it is so sensitive to when the patient coughs or when they're moved or transferred. So that's an issue. Like when we start to wake them up from sedation, they're doing a lot of movement, activity, coughing, they're agitated. It's constantly setting off the CRRT, and it can actually alter the blood flow. So anytime we know blood flow is slow through a circuit, we run the risk of clot formation and run the risk of losing that circuit. In certain situations, we have to use heparin to make sure that the circuit does run correctly because it makes sense, right? We're taking blood from inside a person and we're putting it out to kind of room temperature, right? So the blood doesn't like that. Immediately, the first thing it wants to do is clot, okay? So in some circumstances, we have to use heparin or calcium citrate or citrate. And in some circumstances, the patient, there's an increased risk of developing something known as HIT. With heparin, it's called heparin-induced thrombocytopenia. For the patient, it's considered an allergic reaction. So if the patient was getting heparin, it should be listed as an allergy. But these patients have a consumptive process of their platelets. Their platelet count drops significantly. So that may be an adverse effect of CRRT if we need to use anticoagulation to keep the filter thinned. Obviously, line infection, right? Especially the longer it stays in. And, if we're doing a lot more manipulation and using that line, even though we're using a septic technique, and if we're changing the dressing, insertion is sterile. I mean, the more you utilize it, the more opportunity you have to breach, the barrier. And then increased risk for anemia, and that really has to do with the amount of blood that is in the circuit initially, and then sometimes if we have problems with the circuit and we're not able to give that blood volume all back to the patient, it can lead to anemia. All right, so this is kind of what the machine looks like in an ICU. Soft touch screens. And this is like an older machine, but this is kind of the filter right here. And if you can see kind of on one end, you've got the blood of the patient that runs down. And then on one end, coming up from either up top or down below, you've got the dialysate solution that also runs in the filter alongside the blood. Never mixes. And that's kind of how the process of diffusion and osmosis works. Yes, that's scary. All right, so what's your nursing care? Obviously, vital signs. Even though this is a slow, continuous removal of toxins, removal of excess fluids, their blood pressure can still drop, so we need to make sure we're monitoring it at least hourly or as needed. Daily weights is always important. Even though we're not taking as much fluid off as we do with hemo, we still need to make sure we're getting daily weights. So most often, obviously, it's going to be a bed scale because these patients are not getting up. Adequate I&O. It is the most important component as far as how you run the CRRT machine. Okay, and that's kind of, makes sense, right? What the patient takes in, how much are they drinking if they're awake, how much IV fluids are they getting, antibiotics, so what is their total intake for that hour, and what is their output? In some cases there may be no output, right? Because if they're not urinating, they have no other drains. So that intake per hour through the CRRT machine, we actually have to set the machine to take what the person took in out, right? Because that's one of the purposes of dialysis is removing fluid. So per hour, what the patient takes in minus what they take out for output, and then the rest of it that's left over, we have to run and take off through the dialysis. That's why you're going to find with a lot of patients who are doing CRRT, they are constantly, they have a flow sheet that they follow, and it's probably built in Epic, but they're constantly assessing, okay, how much IV fluids did the patient get? How much did they drink? Did they have any other drains or an NG with section that had output? So intake minus output, whatever is that's left over, we're going to run it on the CRRT machine to pull it off that hour. Monitor for signs of clotting. Sometimes the machine will tell you when it's getting ready to clot. Sometimes you actually might see some of the smaller clots within the machine. And then we do worry about clotting within the access device. And usually, that can be minimized by just keeping the machine running well. Okay, we talked about monitoring for signs and symptoms of infection. We do worry about a localized access site infection, but systemic, right? Bloodstream infection from a catheter association, that's very high up there. That's why we like to limit how long PICC lines, central line catheters, venous access devices are in because of the risk of a bloodstream infection. So, moral of the story, we talked about how when we take blood from a patient and now it's on the external side of the patient, it increased risk for clotting. However, if you take blood from a patient and you put it to room air, what does that do for the temperature of the blood, right? It drops it. So now we're going to put it back into the patient. So it makes sense that one of the biggest adverse effects of CRRT is hypothermia. Their temperature is going to drop. So you can always anticipate when a patient is started on CRRT, you're going to have to find some way to warm these patients. Definitely making sure the room's warmer, whether you need to do a bear hugger or just warmer blankets, or sometimes you can actually get a warmer to warm the fluids before you put any IV fluids into the patient if it's applicable. And sometimes you can warm what you put back to the patient through the dialysis machine, CRRT. So if the patient is hypothermic falsely, right, from the machine, temperature won't be a good indicator of a patient if they have an active infection. So you're going to have to be looking at other things, their white count, trending their white count, trending other things, right? If they have like a drop in their blood pressure, increase in heart rate, if they're on the ventilator, has the secretions that you've been suctioning or cleaning changed in consistency? Did they not have adventitious lung sounds, but now they do? Does their chest x-ray look different? Is it suspicious for pneumonia? So yeah, temperature is not a good indicator anymore. It can be a problem. So that's your good assessment skills coming out. And then obviously we're monitoring electrolytes and acid-base balance frequently in these patients. So they're getting tons of blood work, definitely putting them at risk for anemia. We are purposefully doing it to them, unfortunately. All right, so so some of the things that we worry about, right, in the hospital, like peritonitis, we talked about with peritoneal dialysis, hemorrhaging after dialysis, some chest pain and dysrhythmias related to fluid loss, electrolyte disturbances, and potential risk for cardiac arrest. All right, so we talked about with hyperkalemia. This is an important component for you to remember with dialysis and patients with AKI. Hyperkalemia, like we said, we can do emergency dialysis when the potassium level starts to get high. Anything really over 6, 6.5. We said, 3.5 to 5 is kind of the normal variance. Anywhere like between 5, 5.5, I would consider like Kayexalate would be appropriate. When you start to get up greater, I guess, than 6, 6.57, that's when we start to think about maybe emergency dialysis under some circumstance. Calcium gluconate, calcium chloride, IV piggyback push to make sure that we protect the myocardium. Remember, it doesn't alter the potassium level. D50 glucose and 10 units of insulin IV push. And you can use an amp of sodium bicarb, especially if the patient is acidotic as well. That can help. And then just a key point to remember with Kayexalate, we said it's this very thick, sweet, brown liquid that a patient can either drink, it can go through their NG, but we need to make sure that these patients have adequate bowel function to give Kayexalate, okay? So they can't have an ileus, they can't have a bowel obstruction because the whole benefit is to move it through the potassium through the stool and through excretion of the stool. So if we've got an ileus, right, or bowel obstruction, we can't give it. So it's important to check bowel sounds prior to administration. Another thing too, if we do give it and the patient has an ileus, I think it can lead to bowel necrosis. So that's not a good thing. All right, so talking about non-compliant patients with dialysis. Missed appointments, right? So sometimes your patients come into the hospital for emergency dialysis because they weren't able to get to appointments because of maybe transfer issues. They couldn't get there because transportation wasn't available. Some things that we'll see with our patients who have kidney failure and they need dialysis is poorly controlled fluid intake. If it's a holiday or weekend, they don't adhere to the fluid restrictions in their diet. So we will continue to see edema and weight gain despite education and teaching. So it seems like every time they come back on, there's more fluid that needs to be taken off. They might be non-compliant with their medications. Maybe they can't afford them. They don't like the adverse effects. Sometimes that can affect how dialysis is ran or the outcomes. Hyperkalemia, if they're not watching their diet, they're eating whatever they want, missing dialysis treatments. And then obviously elevated BUN and creatinine, which, are toxins, which can alter many things, but other than that, it can lead to encephalopathy, confusion, mental status changes. And so with these patients, we obviously want to know the reasons behind, right? In order to help educate our patients, motivate them, we need to know the reasons behind, right? Is it a financial problem? Transportation? Do they have lack of social support? Spouse? Family? And then just some statistics, right? How many people have kidney failure? 6,600,000 people have kidney failure, and close to 500,000 people are on dialysis. But only 200,000 are living with a transplanted kidney. So kidney disease kills more annually than breast or prostate cancer. And then in 2013, greater than almost 50,000 Americans died from kidney disease alone. So it seems like the numbers are off a little bit as far as the people that are on dialysis and that the people that are actually living with a transplanted kidneys. So those numbers seem like they need to flip a little.